Hello, and welcome back to my second video on ECG interpretation. In this video, we're going to be focusing on conduction problems at the AV node and the difference between supraventricular and ventricular arrhythmias. In our first video, if you haven't caught up with that, then please check it out. I'll put a link in the description and also on the blog piece. But the difference between this video and the first video is that in the first video we looked at conduction cycles, we looked at normal sinus rhythm, and we looked at calculating rate and being able to have a 3D visualization of the heart. But in this video we're going to focus on abnormalities. And before we actually move on to start talking about the sequence to approach an ECG, I think it's important to try and understand what the abnormalities are. Because if you understand the abnormalities, then you're more likely to be able to pick that up when you're looking through the sequence. So we will come to the sequence, but this is the way that I think it's actually, or the best way to approach this series. So we're going to start off by just briefly reviewing the conduction cycle. So if you haven't already seen the conduction cycle or you don't understand it well, then please check out the first video, because I talk about the conduction cycle and then I talk about how that represents normal sinus rhythm. So I'm just going to really briefly recap it with you guys. So we have the sinoatrial node up in the right atrium. That sends an impulse down to the AV node, and then that goes down the bundle of His and then through to the Purkinje fibers, which then causes a ventricular contraction. So just remember, the sinoatrial node passes through the atria, causing atrial contraction, and then the AV node acts as a filter, passes the impulses down, but with a slight delay, causing ventricular depolarization. So we're going to talk about conduction problems first. And problems at the AV node are known as heart blocks. So what I want you to do is try and make this as interactive as possible. That way you'll get the most out of the lecture. So if I talk about a problem, a conduction problem, then try and think about how that's going to reflect on the PQRS complex. So briefly, if you remember from our previous discussion, the P wave is atrial depolarization, so atrial contraction. Then you have the QRS complex, which is ventricular depolarization, so ventricular contraction, and then you have a T wave, which is ventricular relaxation. And the time that it takes for the sinoatrial node to get to the AV node is known as the PR interval. And the PR interval is usually between 0.12 to 0.2 seconds. So between 3 and 5 small squares, or 3 small squares to 1 large square. Okay, so firstly we're going to talk about first degree heart block, which is the first one but also the most simple. So first degree heart block is where there is a delay between the sinoatrial node and conduction passing through the AV node. So if there's a delay between conduction passing from the sinoatrial node through the AV node, how would that present itself on a ECG? So have a think about it and then I'll show you an example. So the way that this would present is, we talked about how the PR interval is the time taken from the sinoatrial node to the AV node. So if there's a problem, it's going to present itself through the PR interval. So as you can see in this example, if it takes longer for that process to take place, then you're going to get a prolongation of the PR interval. So as you can see, this is significantly bigger than one big square. First degree heart block is really, really common. I see it a lot in my practice and have done in my practice of A&E, and it's often unimportant. We tend not to do anything about first degree heart block unless a patient comes in primary care and is very symptomatic. Then you may consider referring, but in an acute sense, if someone has first degree heart block on their ECG, we will often do nothing about this. Second degree heart block is a little more interesting. Now, what happens in second degree heart block is the impulse is passing from the sinoatrial node down to the AV node, but frequently you're having a failure of conduction at the AV node. So you're getting an impulse from the sinoatrial node and it gets to the AV node and it conducts. Then you have another one, it conducts. You have another one, it conducts, and then it will fail to conduct. So how would that process in itself represent itself on an ECG? Well, if we think back to our cardiac conduction, if we have an impulse that conducts, then you have your PR, you have your P wave, your QRS complex, and your T wave. But if you fail to conduct, then you miss a QRS complex. So if there's a regular pattern of a QRS complex missing, then you need to think about second degree heart block. There's two variations of second degree heart block, and it's very important to try and understand the difference between the two, because actually one is more harmful to a patient than the other. And often second degree heart block actually presents itself with bradycardia, so slow heart rate, so heart rate less than 60 beats per minute. So the first one is Morbitz type 1, and Morbitz type 1 is actually quite a common presentation in certain exams because it shows that you understand this process. So in Morbitz type 1, you have the first impulse from the sinoatrial node conducts normally through to the AV node. And then the second impulse, so I'll just pick another color, will take a little bit longer. And then you'll have a third impulse will take a little bit longer. So if you go back to first degree heart block, if it's taking time for that impulse to pass through the AV node, it's going to represent itself as a, I'm not going to give you the answer, so I'm going to give you a second to think about it. But it's going to present itself as a PR prolongation. So every time that conduction cycle takes a little bit longer, that PR interval is going to prolong. So you'll have a normal PR, then a little bit bigger, and then a little bit bigger. And then on the fourth one, or fifth one, or second one, depending on what type of block's present, the final beat will not conduct at this area. So if it's not conducting at that AV node, then you're going to get a failed impulse. So you'll get a P wave, but you will not get a QRS complex. And I can show you that here on this example. As you can see, on this example, there's the PR interval, which is relatively normal. Then the second PR interval, you can argue that it's a little bit bigger. Then the third one is definitely bigger. And then there's the fourth P wave, but this time there's no QRS complex following it. So this is an example of Morbitz type 1, which is also known as Wenckebach. Now, this in itself isn't necessarily dangerous. It's not, the patient isn't at risk of asystole with this. And if you think about why that may be, just from the way that I remember it, is that this ECG rhythm actually gives you a warning to say that we're going to miss a beat, because it gets a little bit longer, it gets a little bit longer, and it gets a little bit longer, and then it misses a beat. So I always think about that Wenckebach is actually giving me a warning that I'm going to miss a beat, or the rhythm is telling me that it's going to miss a beat by getting longer each time. Whereas Morbitz type 2 is different. Similar process in the terms that a impulse will fail to conduct at the AV node, but the difference with Morbitz type 2 is that yes, it conducts, but what will happen is the PR interval will stay the same. So you get a fixed PR, fixed PR, fixed PR, and then it'll skip a beat. So I'll show you here. This is Morbitz type 2. Fixed PR, fixed PR, fixed PR, fixed PR, and then there you go. There you've got that P wave, but you've got no QRS complex after it. So this is Morbitz type 2, and Morbitz type 2 is one that is, it does place a patient at risk of asystole. So when you're managing the bradycardia algorithm, you have to think about whether the patient has Morbitz type 2, because that may then advise or give you the information that this patient may need actual treatment to manage their bradycardia. Now, complete heart block occurs where there is no connection between the atria and the ventricles. So the sinoatrial node is up there in the right atrium doing its own thing, and then the ventricles, they're doing their own thing because they're not getting the impulse passing down through the AV node. So there's a definite problem at the AV node. Now, complete heart block presents itself in one of two ways. It either can present itself acutely, so after a myocardial infarction, or it can present itself chronically if the heart is, there's fibrotic tissue of the heart. Now, I want you to think about how this may present itself on the on the ECG. So if there's no connection between the atria and the ventricles, how would that present? Have a think, and then I'll show you an example. So what we're basically saying is the sinoatrial node does its own thing, and then the ventricles, they do their own thing. So this is an example of complete heart block. Now, the way that I think about complete heart block is if the P waves are doing their own thing and the QRS complexes are doing their own thing, there's no relationship between the atria and the ventricles, and the part of the PQRS complex which represents the relationship between the atria and the ventricles is the PR. Now, the only way to I would say, it's so hard recognizing a complete heart block, because you could say it's a normal rhythm, right? Because there's P waves, there's QRS complexes, it could be normal. But the difference is that, as you can see, this PR interval is abnormal, that one's different, that one's different, that one's different, that one's different, and then you've got obviously random P waves in between it as well. So there is no regulation, there's no regularity between the PR of any of them. Right, cool. So we covered 3 of the problems that take place at the AV node. So when you're looking at your ECG, and we come to our 4th video, which will talk you through the sequence, I want you to think about the relationship between the atria and the ventricles and how that represents itself as the PR interval. Moving forward, we're now going to talk about abnormal rhythms. So with the ECG, abnormal rhythms can occur at one of 3 places. It can either occur at the atria muscle, it can either occur around the AV node, so we refer to that as junctional area, or it can occur within the ventricles. And all of these problems can represent themselves differently. So there's 2 problems here that we're talking about in a broad sense. We're either talking about supraventricular problems, which is everything here. So that includes the junction, that includes the atrial muscle. And then we're talking about ventricular problems. So ventricular problems is obviously your bottom part here. Now, there's a difference between the way that these present on an ECG. So, in a supraventricular problem, there is a problem at the top of the heart. But if the conduction actually makes its way down the AV node, the lower part of the conduction cycle actually works normally. So if the lower part of the conduction cycle works normally, then we expect to see normal QRS complexes. So in a supraventricular problem, the QRS complexes are normal. Unless, obviously, there's exceptions to the rule, especially if you've got a problem with the lower part of the conduction, like a branch block or something like this, then you're going to have a problem with the lower part as well. But typically speaking, in a supraventricular problem, we should see normal QRS complex. However, if the problem is within the ventricles and you have a rhythm which is starting in the ventricles, they pass through what's called a slow escape mechanism, which actually starts within the ventricles. Now, this problem that starts within the ventricles isn't going to have the rapid sequence of events that takes place in a normal rhythm or a normal lower conduction cycle. So the time taken to actually for electricity to flow down the ventricles is going to be delayed. So this will present itself as a broad QRS complex. So if we remind ourselves back to the last video, a normal QRS complex is 0.12 seconds or less, so 3 small squares. But if you have a broad QRS complex, then it's going to be larger than 0.12 seconds, or larger than 3 small squares. And we'll show you some examples of those. So in this video, I can spend some time speaking of bradycardias. So when we talk about abnormal rhythms, we either talk about conduction problems, we talk about bradycardias, or we talk about tachycardias. So I'm not going to focus too much on bradycardias, because bradycardias, the most common bradycardia is going to be sinus bradycardia, and there's lots of things that cause that. But we're going to talk about bradycardias more when we come to my cardiology course. So if you're interested in learning more about actually what different rhythms and how we treat them and what the route to how we manage them should be, or how we interpret these rhythms, then please sign up for my cardiology course, and there'll be a link on the blog page. So we're going to talk about tachys. Tachys are fun. Not fun for patients, of course, but fun in the sense that they represent themselves in acute scenarios often, and they're actually quite interesting to manage. And I've managed lots of SVTs in A&E, and it's actually giving the adenosine, seeing the rhythm change whilst you're giving someone some medication is actually rewarding, because you can make these patients feel better instantly. You can also use things called vagal maneuvers, where I've put a cold towel on someone's face, immersed their face in cold water, got them to blow out of a syringe. All of that can actually change conduction, which is really cool once you see it. And you can, if you've got them on a 3D ECG, you can actually monitor how the rhythm changes. So if someone presents with a tachycardia, it's usually sustained and fast. If it's not sustained, so they're getting it in short spells, we talk about that as being paroxysmal. So you may hear terms like paroxysmal AF, paroxysmal SVT. So these are rhythms that are short-lived and usually revert themselves into a normal rhythm. So we're going to now talk about atrial flutter. as the first one. So atrial flutter is a rhythm which occurs within the atria muscle, so towards the sinoatrial node, and atrial flutter is where the conduction of the atria is occurring at more than 250 beats per minute usually. So the atria are conducting very, very, very quickly, and this can present itself in one of two ways. So what will happen is if the atria is conducting at such a fast rate, you're going to see lots of P waves, right? So usually there's only one square between the P waves if it's conducting at a rate of 300, and the number of QRS complexes vary depending on how many of these beats are actually conducting down the AV node. So let's talk about this representation. So you see there's a P wave, there's a P wave, P wave, P wave, P wave, right? And then obviously you're seeing the QRS complex. So in this representation of SVT, the P's are actually conducting at 300 beats per minute, but the ventricular rate is fairly normal at around 75 beats per minute. If this was a kind of 2-to-1 atrial flutter, then what happens is you actually get P waves followed by QRS complexes at a ratio of 2-to-1. So you get 2 flutter waves, then a QRS, 2 flutter waves, then a QRS. And if you're having that, then that's known as a 2-to-1 ratio. A patient who's got this rhythm is going to be more stable than someone who's got a 2-to-1 presentation. But if we go back and think about flutter itself presents itself with a very characteristic pattern, and we call this sawtooth. So if you see a sawtooth baseline pattern, then you're thinking atrial flutter. So lots and lots of P waves like that. So yeah, that's the way that you remember it. That's the characteristic description that you'll get in your exam, is sawtooth. So if you see a sawtooth pattern on your rhythm strip, then think about atrial flutter. Now atrial flutter is managed a little bit differently to other supraventricular tachycardias. A lot of it's about controlling the rate of the patient. And when we have flutter waves, sometimes what happens if someone comes in with a 2-to-1 block, the rate is so fast that you actually can't see the flutter waves. So in my time in A&E, what we would do is we would give a patient adenosine, give them adenosine, which actually kind of blocks the AV node. It then slows the ventricular rate down, and you can then uncover flutter waves. So sometimes you may think that a patient is in SVT. You can't manage the SVT because they're not coming out of SVT, but when you give them the adenosine, you actually find that it's not SVT, it's actually atrial flutter, and that atrial flutter will then present itself on the rhythm strip. So now we're going to move on to something called junctional tachycardia, which is more likely to be your regular presentation of an SVT. Now, the junctional tachycardia is not the atria which are conducting really fast, it's the area around the AV node which is depolarizing really quickly, so really bombarding that AV node. So the difference with a junctional tachycardia is the AV node is working so quickly that the impulses are actually going down into the ventricles, so you're getting lots of ventricular complexes, as you can see, like this complex here. So there's more or less one big square between the two, so that will represent itself at about a rate of 150 beats per minute. Usually it's in excess of 150 beats. Now if someone presents with that, because it's so quick and the rhythm is actually coming from the AV node, you may not be able to see P waves. So if you get someone with a regular, really fast rhythm in excess of 150 beats per minute and you can't see P waves, then that's your typical presentation of supraventricular tachycardia. And in this supraventricular tachycardia presentation, what you want to be able to do is talk about how you would then manage that. So we've covered quite a lot in this video. So this is the end of the video. I'm going to stop here because I think it's quite a lot to take in, and have a read of the blog piece as well, because there's lots of information. What I shall be doing now is, if you are kind of interested, in the second part of this video we'll be talking about, so in part 3 we're going to actually cover ventricular tachycardia, and then we're going to stop talking about tachycardias and we're going to move on to fibrillation. So fibrillation is a different process in itself, and then once we talked about fibrillation, I'll actually move on to start talking about certain abnormalities within the PQRS complex. So abnormalities within the P, the QRS, and then the ST segment, and then T waves in itself. So If you're interested, make sure you check it out. If you've enjoyed this video and you found it helpful, then please share this with your colleagues, as it'll be really helpful for myself and spreading the work that we're doing at Ask Dr. Sham. Thank you very much. If you've got any questions, make sure you send it to me. You can either do that on askdrsham.com/contact, or if you don't want to do it that way, you can do it at askdrsham@gmail.com. Thank you very much. Take care. Bye bye.